A new idea. In 1973, two physicians published a paper that quietly shifted the landscape of neurology. The paper was short, just a few pages long, but its core idea was powerful. The doctors, A.R. Upton and A.J. McComas, proposed a concept they called the double crush syndrome. Their hypothesis was straightforward. They suggested that a nerve that is slightly compressed or damaged at one point along its path becomes unusually susceptible to injury at another point, even if that second injury is also minor. A small pinch near the spine, for example, could make a nerve in the wrist far more vulnerable to another small pinch. Years after the double crush idea was introduced, a surgeon at Johns Hopkins University named Dr. A. Lee Dellon decided to test the underlying principles in a controlled laboratory setting. He wanted to move from clinical observation to biological proof. His work focused on creating a reliable animal model to study nerve compression. To do this, he used mice. Dellon developed a method to create a consistent, measurable form of nerve damage. He carefully wrapped a tiny piece of soft silicone tubing around the tibial nerve in the mouse's leg. The silicone was not tight enough to sever the nerve, but it exerted a gentle, chronic pressure, a single, sustained crush that mimicked the kind of compression seen in human conditions. The mice with the silicone cuffs soon developed measurable signs of nerve dysfunction. Dellon went a crucial step further. He studied the interplay between systemic disease and local nerve injury. He hypothesized underlying illness could make nerves more vulnerable to compression. He used streptozotocin to induce diabetes in another group of mice. The chemical destroyed insulin-producing cells, creating high blood sugar like type 1 diabetes. Armed with compelling evidence from his laboratory studies, Dr. Dellon began to translate his findings into clinical practice. He reasoned that diabetic neuropathy might be, in part, a compression problem, and that surgically decompressing affected nerves could restore function and relieve pain. This was a radical idea at the time. The standard view: progressive, irreversible metabolic damage, and that surgery had no role. Dellon challenged this dogma. He began performing surgeries to release nerves at known entrapment sites: feet, legs, tarsal tunnel in the ankle. The goal: give vulnerable nerves more space, improve blood supply, allow healing. Initial results were promising. Many patients told their pain was untreatable, reported significant relief, return of sensation, burning, tingling, numbness. By 2005, the accumulation of clinical and laboratory evidence gave rise to an even more expansive idea: the global compression theory. This theory says nerve compression is not only local, it can be systemic, affecting many nerves at once. Certain underlying conditions create an internal environment. Tissues become stiff and swollen, causing widespread low-grade compression. If nerve tunnels and pathways narrow everywhere, nerve function across the body is compromised. A unifying framework for many seemingly unrelated symptoms and conditions. A key mechanism is glycation. Excess sugar molecules attach to proteins and fats, forming advanced glycation end products, AGEs. If widespread nerve compression is driven by stiff tissues and poor circulation, then it follows that effective treatments should aim to reverse these underlying problems. This logic has opened the door to a range of therapies focused on improving the local environment around the nerve. The central goal is to enhance blood flow. Nerves are metabolically active and require a constant supply of oxygen and nutrients to function and repair themselves. When a nerve is compressed, its tiny blood vessels, the vasa nervorum, are also squeezed, starving the nerve of its lifeline. Therefore, strategies that promote the growth of new blood vessels, a process called angiogenesis, have become a key area of research and clinical exploration. One of the simplest and most powerful molecules involved in this process is nitric oxide. It acts as a potent vasodilator, meaning it signals the smooth muscles in vessel walls to relax, causing the vessels to widen and blood flow to increase. Today, the principles born from the work of Upton, McComas, and Dellon are being actively explored and advanced in specialized clinics around the world. These centers operate on the frontier of medicine, combining established surgical techniques with innovative regenerative therapies. One such example is the work of Dr. Richard Jacoby at the Quadratus Stem Cell Clinic in Scottsdale, Arizona. Dr. Jacoby and his team focus on using stem cells and related biologics to treat peripheral nerve conditions. Another pivotal figure in this field is Dr. Neil Riordan, a pioneer in stem cell research. After beginning his work in the United States, he continued his clinical research and practice at a clinic in Panama. Dr. Riordan's work has focused heavily on the use of mesenchymal stem cells and their exosomes to treat a wide range of inflammatory and degenerative conditions. The story of nerve compression is a powerful illustration of how a single idea can evolve and branch into new research and treatment. It began with the clinical observation of a double crush, then grew into a theory linking metabolism, tissue mechanics, vascular health. From a short paper in 1973 to today's regenerative clinics, medical progress in action. The focus moved from a single injury point to treating the systemic environment that makes nerves vulnerable. This broader view offers a more profound, potentially more effective way to address chronic nerve pain. This history gives tangible hope to millions. Diabetic neuropathy may have a treatable surgical component, and that recognition has changed lives.